Slowing my cancer from growing and living longer are two things I want from my metastatic breast cancer treatment.
And with Kisqali, I can have both.
Kisqali is a pill that, when taken with an aromatase inhibitor, helps delay cancer from growing and has been proven to help people live significantly longer across 3 separate clinical trials.
So I have the confidence to live my life.
Kisqali can cause lung problems or an abnormal heartbeat, which can lead to death. It can cause serious skin reactions, liver problems, and low white blood cell counts that may result in severe infections. Avoid grapefruit during treatment. Tell your doctor right away if you have new or worsening symptoms, including breathing problems, cough, chest pain, a change in your heartbeat, dizziness, yellowing of the skin or eyes, dark urine, tiredness, loss of appetite, abdomen pain, bleeding, bruising, fever, chills, or other symptoms of an infection, a severe or worsening rash, or plan to become pregnant or breastfeeding. Long live life, and long live you. Ask your doctor about Kisqali today.
Hello, everyone, and welcome to this special edition of Outcomes for Me Ask the Expert webinar series. Today, we are extremely privileged to have with us a leading expert, breast medical oncologist, who will share with us an update on the latest breast cancer research presented at ESMO, which is the European Society for Medical Oncology meeting. It's one of the biggest oncology meetings in the world that happens annually. Our expert will share insights on the most significant findings and discuss how these new developments may influence breast cancer treatment and care. We're excited to be able to bring you this timely information directly from one of the world's most important oncology conferences with one of the world's leading experts. So thank you for joining us for this important discussion. For those of you who may be joining one of these webinars for the first time, my name is Suzanne Garner. I'm Director of Marketing and Community at Outcomes for Me. I'm also a stage 2 breast cancer survivor, and I came to work at this company after the Outcomes for Me app was very helpful for me in educating myself about my diagnosis. And it also helped match me to a clinical trial that was an important part of my personal treatment plan. This company exists because Outcomes for Me is on a mission to empower patients with cancer by providing personalized evidence-based information and resources through our app, through our platform. So our belief is that by harnessing the power of patient data, so collectively all of our specific diagnosis information and the latest clinical guidelines, we can aim to ensure that every patient can actively participate in their care. Because when we understand our diagnosis more, we feel more confident and empowered to have educated discussions with our medical team. So for today's webinar, I am honored to welcome Dr. Abiola Ibrahim. Dr. Ibrahim is a board-certified medical oncologist and assistant professor at the University of Illinois in Chicago. Her journey in medicine began in Nigeria, where she earned her MBBS degree. She then completed her internal medicine residency at Morehouse School of Medicine, focusing on racial healthcare disparities. Dr. Ibrahim further honed her skills through a fellowship at the University of Chicago, where she specialized in global oncology and clinical trials. As a dedicated breast oncologist, her research and clinical work aim to bridge the global cancer care divide. She's passionate about conducting innovative oncology clinical trials in low and middle income countries, building local capacity and improving healthcare systems globally, implementing evidence-based strategies to enhance cancer care and prevention in underserved regions. Dr. Ibrahim is at the forefront of groundbreaking research, playing a key role in Nigeria's first multi-institutional investigator-initiated phase 2 trial. Her efforts extend beyond individual studies. She's actively working to improve Nigeria's overall capacity to conduct high-quality clinical trials. With her unique background and expertise, she brings a global perspective to breast cancer care, combining cutting-edge research with a deep commitment to addressing healthcare disparities worldwide. Welcome, Dr. Ibrahim. Could you please start us off by introducing yourself and sharing anything I may have missed with our community?
Thank you very much, Susan, for that very expensive introduction. The only thing I'll have to add is that my passion is about clinical trial diversity, being able to ensure that underrepresented patients, especially Black patients, are enrolled on innovative biomarker-driven clinical trials. And we have to have a representation of underrepresented women or minority women on our trials. And because if our tumor biology is not studied, what we have seen is that that also translates to the outcomes of our patient. You know, when we talk about healthcare disparity or breast cancer disparity, sometimes we all think about the healthcare system, but it's beyond that because we have seen studies that have shown that even when patients looked into in some clinical trials, we see that there's a difference, prospective clinical trials where the treatment is the same, where there is no structural balance, or where the tumor, the anatomic breast cancer is about the same matched in that group of women. We see that Black women, especially Black women, do poorly. So my passion is that women, underrepresented women, minority women, whether in the United States or in African countries or wherever in the world, have true representation, so that geographical location should not be directly proportional to survival, and innovation should not drive disparity.
My introduction was so extensive because you've done so much. And thank you for further clarifying this, because your work is so important and so needed. So thank you for dedicating yourself and your life to this what is still just a gapping hole that we need to do better in. So thank you. We received quite a few questions about the research specifically talked about and updates that were presented at ESMO. So I'm going to jump into those. Admittedly, some of it was a little, some of the questions that we received were a little complex for me, and some of the names of the drugs I'm going to butcher. So please give me some grace with that and repeat them so that our members who are listening today get accurate information and pronunciation of things. So I'm going to start out with questions that were surrounding an update. I believe it was a 4-year update for a trial in hormone positive, HER2 negative, early stage breast cancer. So it was the NATALEE trial, which was the now approved second approved CDK4/6 inhibitor in early stage. So the first question was, what are the details on the update from the NATALEE trial looking at Kisqali in early stage breast cancer?
Okay, so I'll first of all quickly give a baseline of what the study was itself for people that are not conversant with the study. We do know that ribociclib, which is the generic name of that drug, added to AIs, Arimidex or what have you, has shown at 3 years to meet the primary endpoint. And the primary endpoint was invasive disease-free survival at 3 years. And it showed that 90.4% of patients with dose drug combination versus 87.1%, and that was significant. So now the update that we see at ESMO this year was, we now looked at, number one, the toxicity of this drug, and what drug modification was, and the ESMO this year really did look at the safety profile, and what we reported on the safety profile and treatment duration, and we showed that 98% of patients that were on this drug had adverse effects of all grades, from grade 1 to whatever, all grade, compared to 87.8% of patients that just took AIs alone. And the adverse effects of special interest were neutropenia and elevated liver enzymes and QT elevation. And we see that patients that had neutropenia, we had 62.5% of patients had neutropenia with this drug combination, compared to 4.6% alone that didn't have ribociclib. And for the liver related adverse effects, we saw that in 26.4% of patients, compared to 11% of patients that did not get the drug combination. And for QT interval prolongation, we saw that in 5.3% of patients. So what does this even mean to us, to the patients themselves? What it means is that there's a high probability, if you're on that drug combination, for you to either have the three most common side effects: neutropenia, elevated liver enzymes, and QT, or QT interval prolongation. And what happened was, when that was seen, they actually dose reduced these drugs. And then the time to see neutropenia or elevated liver enzymes or QT interval was early on in stage, and the median time to see that was about 3 months. And in all this group of patients, we saw that only 7.1% of patients on that study discontinued their drugs just because of this adverse side effects.
Okay. So the update gave us a lot more information on expected side effects and how we might manage those, and the risk and benefit discussion there. So I think that answers the second question that we got, which was what side effects somebody could expect on it. So I do think that I understand that this trial looked at extending, adding a CDK4/6 inhibitor to an early stage treatment protocol for a wider set of patients than the approval for the first CDK4/6 inhibitor. So the last question here for the NATALEE trial is just, if I have this subtype of breast cancer, HER2 positive, hormone positive, HER2 negative, how can I determine if I'm a candidate for this treatment?
One other thing I will quickly say before I move on to that question was, this dose reduction due to side effects did not appear to impact on efficacy. So if the dose is reduced, don't be worried about the efficacy of this drug, So the patients that were enrolled on this study were stage 2 and 3 patients. Specifically, we looked at anatomical and biology of the disease. So for patients that were high-risk node-negative disease, we saw 28.1% of all the patients on the study had node-negative disease. And we see that also the primary endpoint was consistent in this group of patients. So the question of, okay, how are you a candidate for this? It depends on high risk, right? Your physician will determine if you're high risk, and high risk is defined as anatomical high risk with biological high risk. So if the patient has a grade 2 or 3, if they have a Ki-67, which is saying when you do the pathology finding greater than 20%, if you have node negative, but the tumor size is a T3, or you have node positive disease, these are deemed high risk and recurrence on just AIs alone. So addition of the CDK4/6 inhibitor for 3 years is highly suggested.
Okay. Yeah. And 3 years, that was the other difference, right? From the first approved CDK4/6 inhibitor, that one is a 2-year protocol and this one's 3. Yeah. Okay. All right. Thank you. That was a good overview on that one. Okay. The next one is asking about the Tropion Breast 1 trial and specific side effects for that. Well, maybe we could just explain what that trial is first, and any update from ESMO. And then this particular patient was wondering about the side effects for this drug combination.
So at ESMO this 2024, what we looked at was the adverse effect of this drug. And the beauty of the drug was that we saw that this drug actually had less side effects when it's compared to chemotherapy. And what it did look at was, it looked at Deruxtecan versus chemotherapy in this group of patients. And we saw that patients had less side effects, 21%, compared to patients that got chemotherapy of physician choice. And the side effects of special interest, especially with regards to this treatment, was patients that received that had oral mucositis or stomatitis in their mouth, or that had ocular symptoms. They had keratitis in their eyes, or they had the interstitial lung disease. I have used this drug in my practice. I am yet to see, apart from the stomatitis, I'm yet to see any patient suffer from these other side effects.
Okay.
However, we see that on the study, 56% of 56% of patients suffer the oral mucositis, and it's low grade, and this occurred around cycle 2. And then 40% of patients had the ocular side effects, and this occurred about 40% of group. And then when they had interstitial lung disease, when the patient is on cycle 4, is when you see that. And it actually occurs in about less than 5%. I've never seen it before in my practice and even in my institution.
Okay.
So the treatment for this really is just steroid-containing mouthwash for the oral stomatitis. Sometimes I use it prophylactically because that is a very, very, 56% is high. High chance of recurring. So I always put my patients on it before it starts. They have it in them with them as one of their discharge drugs, because before they come and see me in the clinic the next time, it might be worse. So I give them from the beginning as prophylactic. And then for the ophthalmologic side effects, before we start treatment, we get them to see it after ophthalmologist. And for the study, it's every 21 days. Once they're normal, they can just follow up intermittently with the ophthalmologist. And then for the ILD, I would suggest that the treatment is actually stopped. So,
okay. Right. So the treatment,
go ahead.
So the side effects that have been identified, for the most part, can be managed pretty effectively. But the interstitial lung disease is quite uncommon. In fact, you haven't even seen that in your own practice. But if it does occur, that would be the side effect where a new treatment protocol would need to be selected.
Yes.
Yes.
Stop. Sometimes some people would determine to stop and restart, or maybe give steroid. I would suggest that this is stopped.
Okay, because that's a serious one, but thankfully relatively uncommon, very, very uncommon. Okay. So the second question on this study is about the significance of combining the drugs that were in this research protocol. So I'm not sure if I fully understand that question, but is that a meaningful question to you?
Actually, 2 different trials.
Oh,
so,
okay.
Yes, it was 2 different trials. Those are 2 different trials. So I think there's a question as far as okay. The reason the person that posted it is because the first 2 side effects are much more common. Interstitial lung disease is the most feared side effect, and it's very rare.
Okay.
So the question about the significance between combining etelisumab and the SG, which I like to say abbreviation, govitecan for triple-negative breast cancer patient, is still ongoing, right? But the interim analysis that was reported in ESMO 2024 showed that the median free survival was immature, but it showed a trend towards benefits. And we could see that the Atezo and SG versus control was 12.2 versus 5.9 months. But again, it's very immature for us to draw anything. So, but because the interim analysis shows that it's most likely going to be a positive study, so that's why it's continued. And as far as the safety signal for this the combination of this immunotherapy and antibody drug conjugate, what we have seen is that the safety of this drug is just drug combination is consistent with the profiles of the individual drugs. So there's nothing like synergistic with combination of the drug worsening the combination, but we just see the profiles and side effects on both ends.
Okay. Okay. Thank you. Okay, that was it for that particular trial. So the next trial that we got a question on is the Impassion, or the IMpassion 132 trial. And the specific question was about how this research, so this therapy, might affect the prognosis of early relapsing and advanced triple negative breast cancer.
Okay, so the Impassion 132 study actually enrolled patients that had unresectable, locally advanced or metastatic triple negative disease that relapsed less than 12 months after chemotherapy. So they were very high risk, or the tumor
Okay.
was aggressive, right? And what that study, actually the conclusion of the study really was that in this group of patients, there was dismal prognosis with atezolizumab, even regardless of if they had PD-L1 inhibitors. So what that is showing us is that we need to have a biological based definition of intrinsic resistance to immune checkpoint inhibition. And there's an urgent need for us to start thinking about, in this group of patients, how to do drug combination. So a patient that has recalled less than 12 months after chemotherapy, especially in the triple negative breast cancer space, and not the patient that you are going to be giving single agent immunotherapy to, regardless of the PD-L1 inhibitor status. So these are patients that will benefit from combination therapy. Probably they might benefit from the ongoing atezolizumab and govitecan combination trial. We don't know this. We are still waiting on that data to mature. But for sure, the fact that they are able to recall less than 12 months of getting chemotherapy shows that it's an aggressive tumor biology.
Okay, thank you. The next trial is, I don't know if they pronounced it DOLAF, but it's DOLAF. Okay. And so the question was how effective this triplet therapy was for hormone positive, HER2 negative MBC. And the triplet therapy, correct me, but it's olaparib, durvalumab, and fulvestrant. And only the third one I'm familiar with. So please educate us.
So what that study actually looked into was for all comers patients that had metastatic disease were enrolled in that study with hormone receptor positive HER2 negative disease to receive this triplet therapy. And it had a synergistic effect in all the patients that were the subgroup patients. But what we also saw was that there was a higher benefit for the patients that had BRCA1 or 2 mutation. So the median follow-up at 24.6 months actually did meet the primary endpoint of progressive free survival at 24 weeks, which was 66% in patients that did not have BRCA mutation, but patients that had BRCA mutation that were carriers actually had a higher benefit with this drug combination. As far as the safety profile, they had a very, very good manageable safety profile for these patients.
Okay. That's great. Thank you. So we had a few questions about, I believe it's 2 different studies that may have been given updates regarding pregnancy after breast cancer. And the first one was one specific to those patients who have a BRCA mutation. And the study looked to see if it was safe for them to use fertility treatments.
Right. So we have the positive study, right? It's called the positive study. And what the positive study actually looked at is that in patients that were breast, especially in hormone receptor positive patients, where this group of patients needed to be on hormonal therapy to reduce the recurrence of breast cancer. So this group of patients, the question was, well, how can they, what is breast cancer recurrence like once they get pregnant? It's an ongoing study right now.
Okay.
So I won't want to comment too much on that. But one thing I do know is that for patients after treatment completion, it is safe to breastfeed. Um, they and then breastfeeding, meaning, after the completion of the treatment, it's safe to breastfeed or to get pregnant. You have to have that discussion with your OBGYN, your fertility doctor, because then we have to start looking at the half-life of the drugs, the bioavailability of the drugs, and what treatment you are on, or even the kind type of breast cancer that you have. And then for the BRCA mutated carriers, these are patients, whether type 1 or 2, these are patients that have a high risk of having breast cancer or having ovarian cancer. These are patients that outside of if completing their family, we strongly suggest that they get an oophorectomy and a bilateral mastectomy.
Okay.
Right. So once they are getting that, so I think that negates the question of fertility in this group of patients. And these are patients that it's going to be a joint discussion between their breast cancer team and their fertility team. We might start thinking about, well, do you want to do fertility preservation? How high is the risk for that index patient? Is this a patient we want to think about surrogate for? Because, the fertility team is well advanced, in this, especially when you want to have children. But so it's a lot of moving pieces, in answering that question.
Okay. Well, it's great that all of these studies are going on to get more answers for the community on that. But I am following what you're saying, and it's a very individualized conversation to have with your oncologist about what may or may not be possible there.
Absolutely. Yeah.
Okay, the next question is matched up with the Capitello 291 trial. And the specific question is, what are the benefits of AKT inhibitors in breast cancer treatment? So maybe we can explain the trial and what an AKT inhibitor is too.
So the trial really actually looked at patients that had metastatic disease patient that has progressed on CDK4/6 inhibitors, second-line treatment. And what it actually did look at is that it wanted to see the primary endpoint was in this group of patients, metastatic disease, that metastatic disease that had progressed on CDK4/6 inhibitor, that they had maybe liver mets or what have you. And the next line was for them to see if they were going to benefit from AKT inhibitor. So for this study, the Capitello study looked at capivasertib in this group of patients, and that drug is a pan-AKT inhibitor. So yes, it did show efficacy, and it showed that in adding this potent selective pan-AKT inhibitor to fulvestrant as a second line, it showed a superior progression-free survival in all patients. So all patient groups benefited from the capivasertib drug. But most especially, patients that had the PK3 and PTEN alteration or mutation were shown to have more benefit. However, that being said, me personally, this treatment, the side effects is, of course, can actually tip someone into having hyperglycemia. So a patient that is diabetic at baseline, might be when they might need insulin to be able to support the treatment.
Okay. All right, the next question is about the Keynote 522 study. So the specific question here was, can you describe how adding preoperative prem you can pronounce it pembrolizumab why I feel like the companies just make this stuff up to make it so they can laugh at us, to neoadjuvant chemotherapy improved outcomes for high risk early stage TNBC patients.
Mhm. So the way the study was actually designed, it's almost an oldish study. The Keynote 522 was actually designed in the neoadjuvant space. So patients that were going to get neoadjuvant chemotherapy, for the most part, especially in triple negative breast cancer, we prefer to give patients neoadjuvant chemotherapy to see how a patient reacts in vitro, no, in vivo. So when you do that, right, the study actually looked at chemotherapy versus chemotherapy plus pembrolizumab in the neoadjuvant space. And what that study actually did show was that we saw a complete pathological response of 64.8% in patient that in the pembrolizumab group versus 51.2% in the patient that did not receive pembrolizumab. And we do know that when a patient has a complete pathological response at surgery, that is a surrogate for a better survival outcome. So this study also did show that there was a markedly and significant 37% reduction in the risk of event-free survival, requiring it, making it FDA approved, and it's the standard of care right now. So so yes, it does increase outcome, and then it does actually aid pathologic complete response. But again, this treatment is not without synergistic side effects that is known to immunotherapy.
Okay. Okay. So we have just one last question that we collected from our community prior, but then I've been getting several in. So I think I'm going to finish with the last one that we shared ahead of time, and then see if we can answer some of the live ones too. But this last one was about the Destiny Breast 012 study. And the question is asking if in HER2 is now standard of care for MBC patients, HER2 positive MBC patients, specifically with brain metastasis, is what this patient is curious about.
Mm-hmm. So N2 actually has shown extensive clinical activity in our patients with HER2 positive breast cancer with brain mets.
Okay.
And the PFS was about 17 months. It's still an ongoing study. But in that space, I would do, I mean, again, different cases, it depends. If I have a patient with one brain met, depending on the location, this is a patient I might want them to see the neurosurgeon to see if it could be resected, or if it's not resectable, if it could be radiated, SRC. SRS, right? So is this standard of care yet for this group of patients? I'm not sure it is. I don't know the answer to this actually, but
Okay.
I know it's an ongoing study, and in this space we have a lot of things that we can do, especially for our group, for this group of patients. And we know that HER2 breast cancer has a prevalence for brain mets.
Okay. Okay, great. Thank you. Then I'm going to move to some of the live questions, and some just might not be appropriate to answer or we're not prepared for. So no big deal there, but let's just try since we have some few extra minutes. So I'm going to stay on HER2 positive, but this question is in early stage HER2 positive. So so this participant is curious if there's anything new beyond standard of care in early stage HER2 positive disease to help lower risk of recurrence. Anything being studied or anything new?
So if you're taking if you have HER2 positive disease, the question is, I'm trying to understand what the question is,
I believe that she is curious if there's any studies, any clinical trials in early stage HER2 positive disease that may add to the standard of care protocols that we currently have for that
okay,
patient population.
right. So we have the neratidine. So again, you have to first of all determine if the patient has high risk disease of recurrence.
Okay.
Now, patients that have high risk disease of recurrence, this are a group of patients that we can actually give the Panticare high that's the neratidine too. And so it's been shown to reduce recurrence of disease in this group of patients, especially when they have hormone receptor positive disease in addition.
Okay, thank you. This question I might need more clarification from the person that wrote it in, if you're still listening with us. But she asked to please comment on using LDN, which I'm not sure what that is, but you might know, versus aromatase inhibitors for hormone positive breast cancer. I understand there are far fewer side effects. Is it as effective?
I don't know what an LDN is. I'm trying to. What is LDN?
I mean, in this scenario, I know that there are a couple of studies in early stage hormone positive breast cancer looking at SERDs, right?
Yeah.
Instead of aromatase inhibitors.
We have SERDs. We have tamoxifen is old. I don't know. Oh.
Okay.
So, okay, sure, I already responded. All right, so AIs or hormone blocking treatment, as I just saw that,
Yeah.
has been shown to actually reduce recurrence, right? So, and then we have a lot of drugs in the categories of the AIs or the SERDs that can actually mitigate the side effects that you have. And then the question is, what kind of side effects do you have? Right? The kind of side effects that you have are sometimes, for example, arthralgia is in the first 3, 4, 5 months. The hot flashes also, supportive treatment, supportive lifestyle could really help. Hydration. Yes, I see that. Hydration could also help, to address that. So, right. So we have not had any comparative study to look at LDLs versus AIs in this group of patients. So that's why, because the long-term game concern is addressing breast cancer recurrence.
Okay. Okay. So just lack of study
Mhm.
in that particular scenario. Okay. I think these others are kind of too specific. I might need to just be either you can follow up with us through the app, the Ask Now box in the app, or send us an email, and one of our oncology nurse practitioners can follow up on the more super individualized medical questions. For the just few minutes that we have left, because we've talked so extensively about all this amazing research that is going on, I would love just to hear your perspective through your work on patient participation in clinical trials. And if you personally make that a part of your conversation with all of your patients, or how you determine when that's going to be part of a conversation in their potential treatment plan.
So the standard of care really is the first treatment that we should offer to our patients is clinical trials, right? And I encourage everyone to ask about clinical trials when you get to see a doctor, because the treatment of tomorrow is in clinical trials today. The treatment today was in clinical trials yesterday. So you really want to know what is ongoing, you know. By the time a drug or a treatment is in trials, there is actually a strong proof of concept. And we have what we call the PRC, which is a scientific review committee to see the merit of that study. And then we have the IRB who have looked at the ethical merits of that study. So I strongly suggest that you should be on a trial first, because for the most part, the trial is most likely better than what you're taking right now. So it's something that is strongly suggested. Trial, even preventive trials, even once the treatment of breast cancer is completed, learning more about your tumor biology is important, and even survivorship trials. You know, we want to see what works as far as quality of life interventions, because being a breast cancer survivor or warrior, as I like to say, it doesn't just go beyond completing treatment for breast cancer. We want to see what interventions can we do to maximize quality of life.
Okay. That is wonderful, and that is very encouraging, especially because there are so many trials that we can potentially fit with. Do you have any advice for us in the breast cancer community if our oncologist doesn't proactively bring up trials? And I think that scenario happens quite often just due to lack of time, I think, a lot of time, and being able to do the matching of trials to particular patient populations. Do you have any advice on how we can best advocate for ourselves, educate ourselves on trials, and have that conversation with our medical teams?
Absolutely. I think outright accent is helpful. And in communities like this, whereby depending on your location, you can see some trials are going on. I'm at UIC here. We have some trials here. We have some in other institutions, you know. And sometimes if I see that there's a trial that will benefit my patient, I'm happy to co-manage the patient with the other institution where the trial is. So, like I said, it's very important to ask for trial first, because it might just, I mean, like what we just talked about data, you know, we are always trying to improve the standard of care that we have today. You know, 10%, 15%, that's a lot of rate reduction, you know, in or outcome reduction that I think you should be a part of. So asking for even the nurse navigator or the patient navigator that is working with you at the beginning, asking them for available clinical trials can help if you're especially in the community. And sometimes, I mean, studies has been done where we see that there are so many barriers to getting on clinical trials. And a lot of times we own on patient-related barriers. And the truth of the matter is that we also have system barriers. We have provider barriers whereby, yes, providers might be constrained for time, or sometimes we might even think that, well, maybe this patient is not just going to get on the study, and we don't just talk to them about it. So advocating for yourself as a patient and asking for the trial, ongoing trial, or what is new, what is in the pipeline, you know, would get you on a trial, or get the physician to talk to you about the trial.
Yes. Okay. I think that is great advice. Because unfortunately there is sometimes, well, the time constraint, like I said, but also just this bias where the physician may look at a certain type of patient and say, oh, that they won't be able to participate in this for X, Y, and Z reasons, or they won't make the effort, and that's a really unfortunate bias or assumption. And so bringing it up ourselves can really help start that conversation and ensure that we are all having at least the opportunity to participate in this important research. So Thank you. That was great advice. Is there anything that we didn't ask you as a community about regarding ESMO that you were really impacted by or excited about that you learned at the meeting, or did we cover all the major studies here?
It was well covered. The whole major studies was really well covered, and I was very excited about the questions that came out from the community, and I'm happy to very, very privileged and happy to participate in this session.
Well, thank you. We are very happy and privileged that we were able to have you. And thank you to everybody that was on the call. It was incredibly helpful, Dr. Ibrahim. We got through a lot today. So for our community members, again, if we if we did not answer your question or you think of a question afterwards, excuse me 1 second. That always happens when you're live on a webinar. Clear my throat. If you think of a question afterwards, we're going to make a recording of this webinar available in the app so you can revisit the content. And then you can email us at questions@outcomesforme.com, or there's a question box at the bottom of the home screen of the app. And then those questions go directly to our team of oncology nurse practitioners, and they will get back to you on a one-on-one basis. So if you haven't already, we encourage you to download the Outcomes for Me app so that you can communicate with us that way. But thank you to everyone that joined. Thank you again for being with us today. We really appreciate your time and your heart for patients all over the world. So thank you for your work, and thank you for being with us.
Thank you for having me.
Okay, bye-bye.